Good afternoon and welcome to our second of a three-part series in collaborative practice models given by NAP, Interprofessional and Professional, from the Professional Development Practice Committee. Today we have the Midwest Interprofessional Practice Education and Research Center who will be presenting for us. And our presenters, there are four. Our first is Jean Nagelkerk. Jean has worked as a professor of nursing, director of medical, surgical, and ambulatory care services, assistant vice president of academic affairs, and now serves as the vice president for health at Grand Valley State. Our second presenter, Brenda Pawl, is the director of the Interprofessional Education Office and Special Projects in Grand Valley State University, Office of Vice Provost for Health. And in this role, she coordinates functions of the Midwest Interprofessional Practice Education and Research Center, also known as MIPERC, which includes some work group activities, lunch and learn series, an annual conference, and many more, which they will be happy to let everyone know about at the end of this seminar. Our third presenter, Jeff Trytko, is program director at Grand Valley State University with over 15 years of experience in academic health services, education, and clinical trials research, which has directed efforts toward managing interprofessional collaboration, demonstration projects sponsored by federal and private grants. And our last presenter, Denise Ludwig, teaches graduate courses in health speech pathology and assumes responsibility for administrative functions, including assessment and curriculum. Okay, team, up to you.
Thank you. Good afternoon. My name is Jean Nagelkerk, and I'm the Vice Provost for Health at Grand Valley State University and the chair of the Midwest Interprofessional Practice and Education Research Center. For the rest of this webinar, we will call it MIPERC because it's shorter and it's right to the point. So we as a team here are excited to do the webinar on interprofessional collaborative practice. And today's goals, we will go over a brief history of the MIPERC and give an overview of that. We'll talk about the 4 demonstration projects that assisted us in defining and building the collaborative practice model. And finally, we will share best practices, lessons learned, and next step in our consortium. So the MIPERC is a regional interinstitutional infrastructure that was created in 2007 to infuse interprofessional education and practice across our community for safe and quality practice. There was 3 founding organizations for this. It was the Grand Valley State University, the Grand Rapids Medical Education Partners, which was our residency program, and Michigan State University College of Human Medicine. The mission and goals is really to infuse not only in education but also in practice our any type of collaborative practice to improve the quality and safety of care. We're doing that through interprofessional learning through our curriculums. One of our goals is to do student teams and place them into any clinical placement so that they get real world experiences. And finally, any pilot program that we do, we make sure we do research on it so we can get that out into the literature and to share it with others. As you can see, the 27 organizations are not only academic, but they're health systems, health organizations, and also K through 12. When we started this several years ago in 2007, it was kind of trying to find out what we'd all do, and we focused on the Institute of Medicine's core competencies so that we had something concrete to work on. Then in 2010, we adopted the interprofessional education and the interprofessional collaborative practice definition by the World Health Organization. And finally, in 2016, we added the IPEC competency domains and core competencies. As you can see in the MIPERC model on the left-hand side, we started very focused on learners, but we've adapted it. It's any student, any discipline that's health or health related, including staff in the hospitals, any disciplines, as well as community members. The core was our three pieces of the definitions, the Institute of Medicine and the IPEC core competencies. And on the left-hand side, we chose to use the quadruple aim for better health, better care, decreased cost, and clinician satisfaction. Any good organization, we have a wonderful logic model. So when we developed our interprofessional collaborative practice program, we based it on a team-based approach for the provision of care to improve communication and to enhance the quality of care. We integrated health professional students into the clinical space because we thought that was so important for them to learn how to be collaborative. And then what we learned as we did our demonstration projects is we needed foundational information in interprofessional education and clinical practice for them to do, for both the students and the preceptors to be successful. So we designed modules and resources for them to use and support them. What we have resulted now for the components of our interprofessional collaborative practice program is our 4 foundational modules, which includes an interprofessional education foundations, patient safety, team dynamics, tips for implementing healthcare behavioral change. The structured interprofessional activities are things such as we give them a preceptor manual, interprofessional manual, collaborative care plan, and then we have a set of guidelines that they can pick and choose to use. So now we're going to move into the application to clinical practice where we did these studies that helped us design the model. Our first demonstration model is the Safety Culture Transformational Study. This was funded by Blue Cross Blue Shield of Michigan Foundation and Blue Care Network. The project partners included the residency program, Grand Valley, the Helen DeVos Children's Hospital, and Michigan State University College of Human Medicine. The project's goals was to design a study where students could get the same safety knowledge as staff were getting. Secondly, we wanted to enhance health professionals' ability to communicate effectively among the team. And finally, to look at staff and student safety practices and improve them. We had 203 participants, 37 medical students, 78 undergraduate nursing students, 40 pediatric residences, and 48 nurses and technicians. The measure methods were quasi-experimental. The 2 independent study variables were basic safety training instruction and participation in simulation and safety rounding. We utilized multiple tools, but the main ones was our knowledge test and our safety dashboard, and then program evaluation. The 3 different components of our study was the didactic safety instruction, which is 2 hours interprofessionally based, given by a physician and a nurse. The second piece was 9 video vignettes that they learned from and then were debriefed with, followed by an active simulation. And the last thing was safety rounding in groups of 4. The outcomes of the study included the development of the MIPERC foundational module, because what we learned was the Helen DeVos Children's Hospital required safety training for everybody. And so all students then needed to get this. So we developed an online module. We compared it to the face-to-face knowledge scores and they were equivalent. So we used them in the future. All levels of both face-to-face and online was a positive knowledge gain. We had positive feedback from participants saying that it helped them with critical thinking and decision-making, that the didactic instruction and enhanced their safety knowledge. When the participants went through the safety rounding, they said it was an exceptional experience to sit back and see the efficiencies in communication, what they could do differently. And finally, our dashboard showed that we had fewer safety errors than the other units, but we had more near misses, where they learned from that. Now I will move over and let Brenda describe the second demonstration study.
Hi, test of an interprofessional collaborative practice model to improve obesity-related health outcomes in Michigan. Our governor made obesity a healthcare priority because over 31% of our adult population were either overweight and or obese. I'd like to acknowledge the funding by HRSA that awarded to Michigan Department of Health and Human Services. You can see our project partners were quite robust. We had 2 nurse-managed sites that we implemented this model at. One is Grand Valley State University, and that is on the west side of the state in Grand Rapids. And then the Wayne State University College of Nursing, their Campus Health Center, which is on the east side of the state in Detroit area. We also would have monthly meeting convenes so that we could discuss our findings and progress towards our goals. Our goals, you can see, are to demonstrate interprofessional collaborative practice leadership with our nurse practitioners. We wanted to be able to put teams of students into training opportunities into these 2 pilot clinics. And then, of course, we wanted the dissemination and sustainability of an IPCP clinic-based innovation through the statewide initiative, which was huge. The Campus Health Center at Wayne State University had a little different configuration of leaders than the Family Health Center at Grand Valley. You can see Campus Health had nurse practitioners and they had dietitian and physician. Over at the Family Health Center, we had nurse practitioners, social work, and we had physician. And you can see the composition of the student learners teams were just a bit different as well. The other thing is Campus Health Center served the university student population, and the Family Health Center took on, it was in an urban setting and it did the whole life continuum. So a little bit different population settings as well. So examples of interprofessional collaboration, we had the obesity program interventions, which were just a little bit different at each site. Pretty much over at the Campus Health Center, what they focused on were food logs and goal worksheets. At the Family Health Center, it was focused on, we had modules with overall wellness, nutrition, movement, and behavioral health. So the coaching was just a titch different as well. We did have things in common, such as all the clinics participated in huddles, they participated in collaborative care planning, evaluation of the patient goals, and then we also had weekly case study presentations to staff. And let's look at some of the outcomes, our patient outcomes. You can see we had about a modest 4-pound weight loss at both sites, but 70% of our patients did lose weight, so we were pretty excited about that. And the faculty and staff education data, we showed great knowledge gain. So again, we were demonstrating, you know, the feasibility of using the content that we did use. And we did demonstrate the potential of an IPCP program to affect weight loss in 2 totally distinct populations. So what I'd like to do is introduce Jeff Trytko, and he's going to speak to using these modules that we developed for the MIPERC study in a traditional clinic setting.
So this third project is the Improving Outcomes in Adults with Diabetes through the Interprofessional Collaborative Practice Program. We were published in the Journal of Interprofessional Care in November 2017, where there are more details on our project there. We've narrowed down the scope of descriptions for this presentation. We received public and private funding from Blue Cross Blue Shield of Michigan Foundation, Michigan Department of Health and Human Services and Health Innovations Grant, and also the National Center for Interprofessional Practice and Education at University of Minnesota. This project ran from the fall of 2014 till the spring of 2018, and the project partners included FQHC, Cherry Health Street Services, conveniently located 2 miles from our health campus. Members of our office included at Grand Valley Vice Provost for Health, our PAs from the GVSU program, medical students from Michigan State University, as well as pharmacy students from Ferris State University. You'll see here the diversity of the staff team. We were inclusive of the patient registration staff as well as community health workers among the physicians, of 20 total over this period of the project, and also of students, the diversity of the students there equaling 26. Our project goals were really about implementing interprofessional teams of health students at the FQHC, primarily focused on improving practice efficiencies, as well as improving health outcomes, patients' diabetes. You'll see in our paper, we highlight also the triple aim, which was a focus as well. You'll see here, we also introduced the interprofessional modules for all staff and students, is what Dr. Nagelkerk had spoken of, as well as the resources, the IPCP guidelines that were really essential for navigating the collaborative activities for the students engaging the staff and patients. For learner outcomes, for each of the learning modules, we did pre and post tests. We asked program and evaluation surveys from all staff and students, and we did routine focus groups for providers, staff, and the students. And you'll see here with learner measurements, the pre and post tests, both staff and students showed a significant increase in knowledge among all the modules except for interprofessional education. Interestingly, we found students often are engaged in IPE as part of their programs prior to clinicals. And for the staff at the FQHC, they're very much engaged in team steps and other team building activities. For healthcare outcomes, we wanted to look at the laboratory results of the patients with diabetes. We had about 250 in the first year. And we also want to look at provider practice efficiencies. You'll see here for the high-risk study patient population, that included those with a hemoglobin A1C of 7% or greater, indicating the need for medical intervention. And you'll see here we saw a decrease in the A1Cs. We also saw a decrease in glucose, blood glucose, as well as a few of the lipid protein panels. One thing that was interesting as well is looking at how the team intervention for students would impact provider proficiency efficiency. And you'll see here at baseline, they were a steady increase of productivity per the demands of the Affordable Care Act and their needs there. And when we started introducing the student teams, there was concern that they were going to adversely impact productivity of providers, taking time away from other care activities. But you'll see here, we actually continue to see a steady increase of their productivity, which we're really happy to see. And overall, the key to our success was really getting the routine feedback from the staff and the students and the providers. It allowed us to modify our guidelines so it fit that environment specifically. So it did not adversely impact not only productivity, but also the satisfaction and morale of the staff. So next, we wanted to see how this intervention could be implemented in other clinical environments. And Dr. Ludwig will speak about our fourth intervention.
Hello. The fourth demonstration model is structuring interprofessional collaborative teams in a rehabilitation practice environment. And this example represents a variance in application of the MIPERC model by shifting to educational content. And the project was geared to move from an institutional model to a residential model to see if the model would hold in a specialty clinical practice. The funding for this project was provided by a health innovation grant by the Michigan Department of Health and Human Services. The facility for this project was a residential skilled nursing setting in a Midwest urban area. Partners included facility staff from all disciplines, facility administrators, university clinical faculty and students from the fields of speech-language pathology, occupational therapy, dietetics, movement science, and social work. The three-part model is a strength in that it includes learners, competencies, and outcomes and closes the loop for learning. Participants also included patients admitted during the project time period between July 2016 and August 2017. The project goals included staff and patient satisfaction, staff and student knowledge about interprofessionalism and interprofessional collaboration, and practice efficiencies. Examples of interprofessional collaboration learning activities among the university students that were placed for clinical rotations included a dysphagia project facilitated by dietetics and speech-language pathology for development of a cross-discipline screening tool. And tools were developed, implemented, and evaluated by a larger team that included facility preceptors, university faculty, and students. Movement science and occupational therapy university students worked collaboratively with administration of a functional movement tool among residents of the facility. Multiple instructional methods were used for cross-training of disciplinary content and scopes of practice with university students placed for clinical rotations. Outcomes of participation by students in clinical rotations included a significant focus on jargon-defined communication and knowledge of scope of roles. The protocols used to measure learner outcomes included the MIPERC IPE modules and the IEPS. Both student and staff focus groups were conducted to evaluate the implementation of the IPCP program, and findings revealed new learning about, first, the importance of communication with people in other professions, as well as within one's own profession. Second, the significance of communication among disciplines when caring for patients. Third, the importance of creating cohesive teams. Fourth, professionals needing to work together on complex cases and recognize the importance of interdisciplinary teamwork and communication. And fifth, an increase in the perception of respect for those in other fields and in feeling respected. Healthcare outcomes indicated a significant positive impact for staff in the skilled nursing facility using the MIPERC model. Two salient themes emerged: the importance of communication identified by staff and the importance of contact between direct care and therapy staff, which for many participants was a new experience. Job satisfaction and IPE perceptions were evaluated, revealing positive changes pre and post for both. IPC knowledge was evaluated, demonstrating significant increase in knowledge of patient safety, team dynamics, and an understanding of team member behaviors within roles. A primary takeaway from this exemplar was the demonstrated increase in practice efficiencies using the MIPERC model. And with that, I will turn this over to Dr. Nagelkerk.
So we looked at our 4 findings from the demonstration projects and looked at what the evidence was showing in the literature. And what we discovered is we supported their outcomes. We had improved staff satisfaction, improved patient outcomes in our studies, improved communication, decreased burnout, and improved morale. For communication, we found that our daily huddles were essential. They would bring up thorny issues and be able to resolve them. They didn't have as many callbacks after the patient left. We had lots of individuals saying in the focus groups that communication was more effective, and we appreciated the students' participation in these. Finally, our next steps is to co-create interprofessional clinical learning environments to place student teams, to carefully consider what the preceptors would like, the numbers of students, the types of learners, and the types of resources that they need to be successful. We're going to build and test an interprofessional preceptor toolkit to support the preceptors as they need small bites to get through the day and to utilize those resources to assist with quality learning experiences. And finally, we're going to introduce telehealth technology to do simulated learning experiences for students to demonstrate different types of interprofessional education and skill development. With that, we'll turn it over for questions.
Thank you very much, team. Before we entertain questions, we do want to know how we can retrieve and receive additional data about MIPERC and information about the current initiatives you're working on.
Well, thank you. We do have a website. It's www.gvsu.edu/MIPERC. And you can get information about our events, our activities, and the conference. We do have a conference coming up that is going to take place in September. And it will be September 19th through 20 in Grand Rapids, Michigan. And I think that Melanie can share that with the participants if she'd like.
We do have some questions if we have some time, Melanie. What data management systems did you use among the different settings involved to coordinate data entry and retrieval and analysis?
We used a lot of, we used, because we did a lot of online education, we used Blackboard Advanced 360 for data entry for responses to those different kind of survey questions and pre-post knowledge tests. Of course, everything was downloaded to Excel. And then we had our GAs and a PhD statistician, Dr. Baer, do the statistical analysis in SAS and SPSS.
We have some more questions. How have these interprofessional demonstration projects changed practice from a longitudinal perspective? In other words, have the positive outcomes now become part of the infrastructure given the measurable outcomes?
Yes, actually that did happen in all of the different settings. Cherry Street, the one that did the Federal Qualified Health Center, they continually do daily huddles. They've actually added more individuals to them. They have changed their learner types that they do, but they still do teams of students, but with different learner types depending on the needs of the practice.
In the educational setting, the dual layer of clinical competencies and interprofessional competencies has continued to impact all placements for those disciplines that were involved. And we, as Dr. Nagelkerk articulated, we continue to look for new and improved ways of placing students together in clinical placements.
And the follow-up to that question, are you able to compare these long-term outcomes in other practice settings and institutions?
Well, I think what we have done is we've used different types. So we had a two nurse managed centers, a federal qualified health center. We had a rehab setting. So while we can look at them, we can't say they're equivalent, but we can see that the knowledge gain is there, that the improved communication, and with Cherry Street specifically, we did a 3-year longitudinal assessment over 3 years, and they continued to improve in all 3 years.
Thank you. And we have time for one more question. How has the culture changed related to IPECP among practitioners with the patients?
What I have seen, and the others may have too, is I see that they do more team care. So they pull in other types of disciplines, social work or pharmacy, etc., in team conferences sometimes, and they also pull in students. So I see them being more team-based care and using each other's skills at the appropriate time, whether it's a dietitian, etc. So that's what I have observed.
And in the rehabilitation setting, there was also some recognition by family members of patients and members that there was an increase in this level of communication and understanding dual roles and releasing role content. And I think that was a real positive for individuals in the rehabilitation setting.
Well, thank you very much. If there are no more questions before we end our webinar, I'd like to invite everyone to visit nappractice.org, events and NAP webinars. Stay tuned for the final webinar in this series, which is going to be Building a Culture for Interprofessional Collaborative Practice in Oral Health. That'll be offered on Monday, June 3rd from 3 to 3:30 p.m. Eastern Time, and that's going to be presented by Anita Glicken. And we have a little announcement. In addition, thank you so much for providing a very informative, evidence-based presentation of the outstanding collaborative work in MIPERC. Outstanding work. So kudos to you guys. And everyone, don't forget the 2020 annual meeting and forum. We are sailing on to San Diego, March 12th through the 14th, 2020. So save the date. Thank you all.
Thank you.
Thank you.
Thank you.